Hi, my name is Rashini Kalagara, and I'm a part of the Department of Emergency Medicine group at Brown University. My team's project and what I'm going to be talking about today is titled Training for Failure, an analysis of pre-hospital airway management during witness cardiac arrest in adults. My group has no funding sources or conflicts of interest to declare. So back in March of 2017, the state of Rhode Island released a 30-minute on-scene protocol for pre-hospital providers. This meant that pre-hospital providers had to stay on scene for 30 minutes prior to begin transporting a patient to the hospital. So last year, my group did a study that looked at the effect of this on overall outcomes, and we saw that there was an indication of increased levels of ROSC because of this. So the aim of this study was to evaluate the impact of provider level on airway management before and after implementation of the same protocol. The two levels that we were looking at are EMT cardiac, which is unique to Rhode Island and kind of a bridge between the EMT intermediate and the paramedic level. The EMT cardiac receives about 300 hours of training compared to a paramedic's 1,200 hours of training, and the cardiac is a little bit more reliant on medical control and has fewer restrictions on the medications that they can administer. However, we are most interested in the fact that both of these levels, regardless of their training amounts, are able to place endotracheal intubation and supraglottic airways during a cardiac arrest. So we conducted a retrospective cohort study using ED and pre-hospital records pre and post implementation of our protocol. The outcomes we were most interested in included initial airway, the highest attempted airway, and the final method of airway management on scene. We were also interested in the overall success rates for endotracheal intubation. So as you can see here, in terms of initial airway management, we did not find any significant differences between what cardiac or paramedic would choose pre and post protocol implementation. The majority of them reached for a back valve mask, and other options included passive oxygenation, supraglottic airway primary, or endotracheal intubation. The next thing we looked at was the highest airway attempted and the provider level. We did find significant differences in the overall pre versus post group and the overall cardiac versus paramedic group. And we weren't able to pinpoint exactly where this variation came from due to our N size and due to this being limited to 6 months pre and post the implementation change. So the next thing we looked at was the final airway and provider level. We also found significant differences between the overall cardiac versus paramedic choices and in the pre-group between the cardiac and paramedic choices. Now, two additional categories on this graph include SJR, which stands for supraglottic airway rescue, which means that this was placed after a higher level of airway, generally intubation, failed. And another interesting thing is unrecognized esophageal intubation, which means that this intubation attempt failed, however, was not recognized until the patient was brought to the emergency department and where it was fixed. And so this is another area of that we're kind of targeting for future protocol updates. And so the last thing we looked at was the differences in endotracheal intubation success rates between provider levels, and we didn't find any difference in these overall success rates. So because of our granularity of our data, we were able to create airway decision maps between these provider levels. So we could see generally when a provider came onto scene, what choices that they would generally start off with and how their airway decisions would go while they were managing this cardiac arrest. Now, as you can see from the cardiacs, the majority of them started off using a BVM, and then they would generally progress using endotracheal intubation. Now, depending on if this was successful or not, they would follow many different paths from here. We created a similar diagram for paramedics. The majority would also start from BVM and progress to endotracheal intubation, but they would follow a few different paths from this point. So a couple of limitations of our study is there are variations in EMS protocol adherence and PCR documentation. Although the state does release protocols, various systems might have their own protocols that they follow and have different standards for documentation, which are the records that we use to pull our data for this project. The next thing, as I talked about earlier, we were limited to 6 months pre and 6 months post implementation of this protocol. And currently we're conducting more analyses to grab more patient data so that we can figure out where the variation between these provider levels is actually coming from. So from this study, we were able to find significant differences in the highest attempted and final methods of airway management. Although we found similar overall success rates for endotracheal intubation, these differences might be the result of increased BVM use versus rescue SGA placement following unsuccessful endotracheal intubation among cardiacs. With further analysis, we will be able to generate more airway maps, and so we'll be able to confirm or deny whether this hypothesis is true or not. However, this research is very essential because it will help us see what different provider levels in Rhode Island see when they come onto scene and how this can affect the choices they make, affecting overall outcomes. And with this interim data, we are very excited to continue our work to have further recommendations for our protocol updates in the future. Thank you.